joining for this today's session. Today we'll be discussing a very important topic, ABG analysis, which we come across day in, day out in our ICU setups. And my main aim of today's lecture is to make you all understand the very basics of the ABG and its interpretation in a very simple way, as easy as I could make it for you people. Okay, so don't get scared. It's going to be a bit long, but I think by the end of it, you should be able to manage to read an ABG. Okay. So towards the end, I don't want anybody to be scratching your heads after seeing an ABG, and everybody should be comfortable enough to interpret a easy ABG in a very easy way. Okay, I would just request everybody to keep a pen and a paper or a calculator beside you so that while we go through the presentation, we can make the calculations easy for you. Okay. As we go through the lecture, we'll be dealing with the introduction part, indications of ABG, contraindications, complications, the sampling technique, ABG versus VBG, that is the venous blood gas, and its interpretation, some MCQs, and then case scenarios, which we'll together solve. Okay. So to begin with, a normal pH is basically necessary for an optimal functioning of all cellular enzymes and metabolic activities. Thus, any alteration in the pH leads to imbalance in the body's acid-base status, which can cause disruption in the normal functioning and can be even life-threatening and fatal. Okay, so to maintain this constant pH, the ratio of the carbon dioxide and the partial pressure of the carbon dioxide and the bicarbonate should remain constant. This is given by the central equation, which is the backbone of all the acid-base physiology by Henderson and Hasselbalch. The simplified version of it is hydrogen ion concentration is equal to 24 into PaCO2, that is the partial pressure of carbon dioxide, by the concentration of bicarbonate. I just want to highlight that, remember this equation for the further discussion. If one of these components is altered, then the compensatory mechanisms in the body tries to alter the other component in the same direction to keep this ratio constant, to maintain a normal pH. Okay, what does that mean? That if the CO2 level increases, then the bicarbonate will also increase to maintain the certain ratio, or else if the carbon dioxide level decreases, then the bicarbonate will also decreases. Okay. So what are these compensatory mechanisms in the body? There are three major ones. One is the chemical buffers. These are the first line of defense. It acts the fastest, that is within seconds. And it includes the extracellular and the intracellular buffers like bicarbonate, ammonia, protein buffers. Okay. And how does it act? By removing the H+ ions. Okay. Second line of defense are the lungs. They act within minutes to hours, and they act by eliminating or retaining the carbon dioxide. Third is the kidneys. It is the slowest, takes hours to days to compensate the mechanism, and acts by retaining the bicarbonate or by eliminating the H+ ion via urine. Okay, so for normal functioning, it's like a scale balance. We have to maintain the balance between the acid and the base. Okay, in the ABG language, we'll be dealing further. Wherever I say respiratory, you just remember it has to deal with carbon dioxide, and acid should come to your minds, and lungs. Okay, when I talk about metabolic, the two things which should come into mind is base and bicarbonate. Okay, and to maintain for all the calculation purposes, the pH we'll take it as 7.4. Okay, so arterial blood gas analysis refers to the measurement of the pH and the partial pressures of the oxygen and carbon dioxide in the arterial blood. Okay, from these values we can assess two major things. One is the acid-base status in the blood, and second, how the lungs are performing their gas exchange. Okay, so you can see ABG will tell us about oxygenation, the ventilation, and the acid-base status. So what are the uses? To establish a diagnosis. Okay, supposedly a COPD patient, comes with breathing difficulty, drowsiness, then we do a ABG. We see a raised CO2 levels. That is, we call it a type 2 respiratory failure. We know what to do next. We need to apply an IV or we need to intubate a patient. Okay, so supposing to establish a diagnosis, to assess for severity of illness. Okay, how bad is the disease? Okay, to look for the acid-base disorders, electrolyte abnormalities, and to guide and monitor treatment. Okay, supposedly this COPD patient, we have applied the NIV for 2 hours, then we repeat a ABG. Okay, supposedly the carbon dioxide improves, then we need to continue the NIV, or else we'll think of putting the patient on an invasive ventilation. So to guide us for the treatment also. Plus the patients who are already on a ventilator, you know that we keep on doing ABGs to modify the ventilatory settings to wean the patient. Okay, so this all tells about the monitoring as well. Contraindications when not to do the ABG. So when you have whatever site you've chosen, if there's an overlag infection, there's some burn, there's absent or inadequate collateral ulnar circulation, that is the negative valence test. This I'll tell you in detail in the next subsequent slide. Coagulopathy, if the patient is bleeding, if the platelet is low, very low, risk of bleeding is very high. Atherosclerosis, severe peripheral vascular diseases, Raynaud's diseases, or there is a fistula or a surgical graft on the same area. Complications, ABG is a painful, method. So you need to apply a local anesthetic also. Local hematoma can occur, bleeding can occur, the artery can go into spasm or occlusion. You can cause infection. If you apply a local anesthesia, can cause reaction also. Very rare chances of thrombosis and embolism. You can injure the nerve around that area, and sometimes the vasovagal response can occur to the patient where the patient gets drowsy, syncopal attack. Okay, so what do you keep in mind before sampling? So confirm the need for the ABG, whether you need the ABG or not. Identify any contraindications. Always record the details of oxygen therapy and the ventilatory support and temperature. Why this is important, I'll tell you later on. But you have to remember, when you do a ABG, if the patient is having some oxygen, supposedly 5 liters via face mask or 2 liters via nasal prongs, or on a ventilatory FiO2 this, tidal volume this, so you need to record all this on the ABG, because the PO2 level, CO2 level, everything we'll judge on the basis of whatever record details you've kept on the ABG. Plus temperature is important, because temperature has a major role. If you have some high temperature, low temperature, then the ABG will be also variable. Okay. Unless results are required urgently, allow at least 20 minutes after any change in oxygen therapy before sampling. What does it mean? That if you've altered the oxygen, supposedly 5 से 2 किया है या 2 से 5 किया है, so you need to wait for at least 20-30 minutes to do an ABG. Okay, don't do it immediately within 5 minutes. Then the steady state won't be achieved and you won't, see a good example of PO2. What you want to see. Explain to the patient why you're doing the test, what it involves, and the possible complications. Then obtain consent and proceed. Okay, prepare the necessary equipments needed and don universal precautions. Okay, identify a suitable site for sampling, which can be any radial artery, brachial artery, femoral artery, or dorsalis pedis artery. The commonest we use is the radial artery. Routine sampling should be on a non-dominant arm from the radial artery. Okay. What is the technique? So before we start taking the sample, we should perform a modified Allen test to ensure that the ulnar circulation is intact. Okay, because you're going to prick the radial artery. So if the other artery is not supplying, then it's in danger. Okay, so how do you do this test? What do you ask the patient to clench the fist first? Okay, and then you occlude the arteries, both radial and ulnar, from both of your hands. Okay, as you see in this picture. In the second, you ask the patient to then open the fist, and you see, since you've occluded both the arteries, the palm will be blanched. Okay, it will go white. Now slowly release the ulnar artery with continuing the blockage on the radial artery. Okay, if the circulation is intact, the palm will go pink again within 10 seconds. Okay, this signifies that there's a adequate collateral ulnar circulation, or the positive valence test. If you see all this, then you can continue with your radial artery sampling. Or else, if you don't find this, or if it is taking more than 10 seconds to go pink, then you should change your site or think over of taking a ABG. Okay. Sampling technique: position the patient's hand with the wrist extended 20 to 30 degrees. Greater extension of the wrist may impede the arterial flow. Okay, do not overextend the wrist. Identify the radial artery by palpating the pulse. Choose a site where the pulse is prominent. Clean the sampling site, expel the heparin from the syringe, inject the local anesthesia, okay, around the site, steady the hand of the patient, insert the needle at 45 degrees with the bevel of the needle facing up. Be sure to insert the needle very slowly to minimize the risk of spasm. And once you enter the artery, a flash of pulsatile blood will appear in the needle. Obtain at least 2 to 3 ml of blood sample before taking the needle out. Okay. Now we have always this confusion that whether it's arterial or venous, don't go by the color as such, because if the patient is in shock, cardiac arrest, or high CO2 levels, even the arterial blood can be a bit dark. Okay, so what do we see? On the ABG, we will see the SO2 levels and we can judge on the basis of that. Okay, as we know that venous blood is deoxygenated, so it will have a lower SO2 levels. After sampling, what is important? Once you've obtained the sample, remove the needle, apply firm pressure. This is very important. Don't leave the prick site open because it might bleed, because it's an arterial puncture. So apply direct pressure to the site for at least 5 to 10 minutes. Dispose all the sharps. Ensure no air bubbles are present, because again it will change our ABG values. Okay, and the sample, if you think that it's going to take more than 10 minutes to do the analysis, then the syringe should be stored on a crushed ice. Okay, if sampling is unsuccessful, it's often advised to repeat the test on the opposite wrist, as even slight irritation will let the artery to go into spasm and you won't get any puncture next. Okay. So what are the factors affecting these values? The first one is the temperature. Okay, the patient's body temperature affects the value of the CO2 and bicarb levels also, as the ABG analyzer is controlled for the normal body temperature. So if there is some variation, you might have a different PCO2 and bicarbonate level. Okay, so always send the ABG sample with information of the oxygen, FiO2 and temperature. Next factor important is the heparin. Nowadays, we have a pre-heparinized syringes. We don't need to take heparin again and again, but some setups still have the older version. So in those cases, you take the syringe with 0.5 ml of 1:1000 heparin, okay, and empty it. Do not leave the excessive heparin in the syringe because it has a dilutional effect, okay. It will decrease the bicarbonate and CO2 levels in your ABG sample and you'll have a false reading. Okay, only 0.5 ml should be used and you should discard it. Always fill the blood sample in the syringe more than 50% of the volume and take usually 2 ml syringe, not more than that. Next factor important is the air bubble. Ensure that when you take the sample, there should be no air bubbles, because contact with the air bubbles, you'll have again a different value. There will be a high PO2 because of the air bubble having PO2 150 and a decreased PCO2 value. Okay. Last one is that you should maintain a cold chain. If you think that you need to transport the ABG to some other area to interpret, or there's some time taking more than 10 minutes, then you should keep your sample in the cold ice or cold chain, because every 10 minutes, if you'll see this table, if the sample is not kept in ice, the pH will change by 0.01, but if you've kept it into ice, it will change by 0.001, which is hardly anything. PCO2 will change by 1 mm, but in an ice sample, 0.1 mm, and PO2 0.1%, and ice sample 0.01%. So these factors you should keep in mind: temperature, air bubbles, cold chain, and heparin level. Okay. Just a slide on the differentiation. So nowadays, the popularity of the venous blood gases are also increasing, especially in the emergency department, because even VBG can yield almost similar information. okay, apart from oxygenation. So VBG is much quicker to take, simpler and less painful, also avoiding the arterial complications. Okay, and nowadays in DK guidelines also, earlier we used to prefer ABG, but now in the DK guidelines also they are advising that you can take VBG to provide enough information for clinical decisions. Also, the pH value in the VBG and ABG is almost similar, just 0.5 difference. So again, you can consider to screen the overall acid-base status in a VBG as well. And also the bicarbonate value is also similar, so you can assess the bicarb also. What are the limitations? Since you know the VBG is a venous blood gas, it's a deoxygenated blood, so VBG cannot be used to assess the oxygenation. Also, PCO2 measurement, that's a poor agreement, so you should avoid seeing the PCO2 also in VBG. But if you have a PCO2 less than 45 in a VBG, then at least you'll know that arterial hypercapnia also is not possible. Okay. Similarly, if you have a normal lactate level in a venous blood gas, so also in the arterial also the lactates going high is less likely. Most important is, since when we take a venous sample, we apply a tourniquet, so it causes a regional ischemia and causes a local acid base alteration. Okay, so when you plan to take a VBG, at least try to avoid it if possible, or if you've already applied, try to take the VBG after releasing the tourniquet 1 minute prior to it. Okay. So this table just differentiate between the values what you see in the ABG and VBG. So pH in an arterial is 7.35 to 7.45. If you see a venous blood gas, it's almost similar, just 0.5 difference, 7.31 to 7.41. PO2 levels 80 to 100 in arterial and venous 35 to 40. So that's why you should not use the venous blood gas for oxygenation purposes. Assess oxygenation. PCO2 almost again similar, 35, 45, 41, 50. Bicarb similar, base excess similar. SO2 level definitely higher in the arterial and less in the venous blood gas. So what all data you can find when you take a ABG? You'll see a pH level, a PO2 level, a PCO2 level, a SO2 level, which suggests the percentage of binding capacity in the blood for oxygen. Then you have two values of bicarbonate. One is the actual, one is the standard. So actual is the calculated one and standard is the measurement which is calibrated against the CO2 at a corrected to 5.3 kilopascals. Okay. So for calculation, we take the standard bicarb value. Lactates, hemoglobin, sodium, potassium, chloride, ionized calcium, glucose, anion gap, hematocrit, methemoglobin, carboxyhemoglobin, osmolality even can be seen on some of the ABGs. Base excess is also an important finding. What does it mean? It's the base that needs to be added to or removed from a sample of blood to achieve a neutral pH. Okay, so if it is a positive base excess, means that is there is more base, that means metabolic alkalosis. And if it is a negative PE, that means there's less base, that is metabolic acidosis. So these normal values you should remember: pH 7.35 to 7.45, PCO2 35 to 45, mm of mercury, bicarb 22 to 26 millimole per liter, base excess -2 to +2 milliequivalent per liter, PO2 80 to 100, SO2 95 to 100%. For calculation purposes, we have to take a single value. So we go for pH being 7.4, PCO2 40, and bicarbonate as 24. Remember these values for further calculations. Okay. Now, the most important part, the ABG interpretation. Okay, you'll come through many steps, many ways to interpret. This is the Boston approach, and this is how you should approach an ABG. Okay, so to begin with, first I've put assess oxygenation. Somewhere you'll find oxygenation coming last also, but I've just deliberately kept it first because rather than reading an ABG, you should first see the oxygenation status. Supposedly the PO2 is only less, then at least you'll apply the oxygen or think of invasive ventilation or a NIV first, rather than going for further interpretation. Okay. So first you'll assess the oxygenation level. Second, check for the validity of the ABG. What does it mean? That whether the ABG is valid means consistent or calibrated. If the ABG is not valid, then you need to do a ABG calibration of the machine. Okay. Third step, which is very important, you need to identify whether it is acidemia or alkalemia. When do you say it? That if the pH is below, for calculation purpose, 7.4, acidemia, more than 7.4, alkalemia. But grossly when we call it 7.35 se niche acidemia, 7.45 se upar alkalemia. Okay. Fourth step, you need to find the primary acid-base disturbance, whether it's the respiratory or the metabolic. Okay. Fifth, if it is respiratory, then we'll find whether it is acute respiratory component or a chronic respiratory component. Okay, understood till now? Sixth, we need to see for the compensation. मतलब कि जितना जो हमारा प्राइमरी एसिड बेस्ड डिस्टर्बेंस है कॉम्पनसेट हो पा रहा है कि नहीं. ठीक है, मतलब अगर रेस्पिरेटरी एसिडोसिस है तो क्या मेटाबॉलिक एल्कलोसिस भी है साथ में, या फिर कॉम्पनसेट हो रहा है, या थर्ड कोई डिसऑर्डर है क्या. ठीक है, तो ये आई विल जस्ट टेल यू इन द सब्सिक्वेंट स्लाइड्स. Seventh, if metabolic acidosis you found as the primary disturbances, then we'll calculate the anion gap. If respiratory, then we don't need to go for this step. Okay. If anion gap is present, then we'll go for delta anion gap. From here onwards, 8, 9, 10 steps, I would try not you to focus. It's more of, when we go into detail, I've just put all this because it will just complete all the steps for the interpretation. But you have to remember at least till 7 steps, which is the most important steps to interpret an ABG. Okay. So if an anion gap is present, we'll calculate the delta anion gap. If the anion gap is a normal anion gap, we'll calculate the urinary anion gap. And if there is a metabolic alkalosis, we'll check for urinary chloride for saline responsiveness. Okay. So, beginning, first step, we'll assess the oxygenation. Oxygenation or a gas exchange can be assessed by various things on the ABG. PO2 levels, SO2 levels, alveolar arterial gradient. This you have to calculate. I'm not going into the details. It requires an alveolar gas equation. It's a very big topic in itself. So I'm not going just to complete the topic. I'm just putting it in your heads that alveolar arterial oxygen gradient. Okay. PF ratio. This you might have heard in ARDS. This is very important. And PSO2. Okay. So any PO2 levels, if you see in the ABG going below 80, it's called as hypoxemia. We have a mild, moderate, severe grading. 60 to 80 is mild, 40 to 60 is moderate, and less than 40 is severe hypoxemia. Okay. A gradient 5 to 25 is normal. PF ratio less than 300. We have again ARDS category, and PCO2 35 to 45 is normal. Okay, so first step, just remember this, I've put it first because if you have a low PO2, at least I want you to intervene first rather than going for further interpretation. Okay, otherwise ABC is lost. Second step, check for the validity of the ABG. As we have discussed this formula prior also, H plus ion is equal to 24 into PCO2 by bicarbonate. Okay, this is known as the Henderson-Hasselbalch equation. Okay, so by using this formula, so you'll find the PaCO2 and bicarbonate value on the ABG. You'll apply it in this formula. You'll get the H plus ion concentration. Here, the table, if you'll see on the right side of your screen, this table is a standard table. And then you'll compare this H plus ion. Supposedly, our H plus ion is coming about to be 50. Okay, so you see 50, the corresponding pH to it is 7.30. Okay, supposedly your ABG also has a pH of 7.30, then the ABG is said to be valid. So you need to calculate first and you have to match up with this table to see that whether your ABG is valid or not. If you have a different data, then that means the ABG is invalid, your machine needs calibration. Okay. Supposedly you don't have this table with you, then there's a shortcut. You calculate this formula 24 into PCO2 by bicarb first. Supposedly you have a value of 50, and you can also calculate the shortcut that 80 minus last 2 digits of pH. Okay, supposedly the ABG has a pH of 7.30. Okay, so 80 minus last 2 digits of pH was 7.30. So 30 you'll take. 80 minus 30 is equal to 50. ठीक है, एंड हमारा कैलकुलेशन ऑफ दिस H प्लस वाला फॉर्मूला से भी 50 आया, तो दैट मीन्स वी हैव अ वैलिड ABG इफ यू डोंट हैव दिस टेबल विद यू. ओके, next we come to few terminologies which you should know before I go further. So there's a primary acid base disorder or a simple acid base disorder. मतलब क्या हुआ, there's a only single acid base disorder. या तो respiratory acidosis है, respiratory alkalosis है, metabolic acidosis है, metabolic alkalosis है. Okay, there's no other hidden other acid base disorder. Okay, compensation, what do we mean by that? That the normal response by the kidneys or the lungs to change in the pH is induced by a primary acid base disorder. Remember, I've told you it in the first slide that if the CO2 or bicarbonate value changes, the body tries to compensate to make the one value in the same direction to maintain a certain ratio. Otherwise, our pH will not be maintained. Okay, so this is the meaning of compensation. What do you mean by mixed acid base disorder? As the name suggests, that there is more than one acid base disorder occurring simultaneously. Okay, so first step we did oxygenation, second we checked for the validity. Now we start the main ABG part. We'll look for the acidemia or alkalemia. Okay, so acidosis or acidemia mein kya farak hai? Acidosis is the process by which the pH decreases by gaining a H plus ion or losing a bicarbonate ion. And alkalosis mein kya hota hai? It's a process which tends to increase the pH by loss of H plus or gain of bicarbonate. Okay, acidemia is the whole condition when the blood becomes acidic. Okay, and alkalemia is when the whole blood becomes alkaline. Okay, so acidemia is pH less than 7.35 and alkalemia pH more than 7.45. Okay, for calculation purposes I told you we'll take pH as 7.4. कुछ भी 7.4 से कम है वो एसिडीमिया लेना पड़ेगा एंड 7.4 से ऊपर एल्कलीमिया लेना पड़ेगा. Okay, a normal pH का ये मतलब है, this note is important, a normal pH can have two reasons. One, actually it's normal, and second, there is some mixed disorder which is causing a normal pH. Okay, now fourth step, we need to identify what is the primary acid base disorder. How do we see? Just remember a simple mnemonic, ROM. ठीक है, रेस्पिरेटरी ऑपोजिट, मेटाबॉलिक इक्वल. क्या मतलब हुआ? We'll just see two things together, pH and PCO2 levels. If the pH is increasing and PCO2 is increasing, ठीक है, और if the pH is decreasing and PCO2 is also decreasing, मतलब दोनों सेम डायरेक्शन में जा रहे हैं, pH भी कम हो रहा है, PCO2 भी कम हो रहा है, pH ज्यादा हो रहा है, PCO2 भी ज्यादा हो रहा है. If they are going in the same direction, that means the primary disturbance is metabolic. Okay, if pH is increasing but CO2 is decreasing, pH is decreasing and CO2 is increasing, मतलब दोनों opposite direction में जा रहे हैं, that means it's a respiratory component. Okay, बस अभी हमें यही याद करना है, रेस्पिरेटरी ऑपोजिट मतलब पीएच और CO2 ऑपोजिट डायरेक्शन में जाएंगे, पीएच ज्यादा होगा तो CO2 कम होगा, पीएच कम होगा तो CO2 ज्यादा होगा, ये ऊपर नीचे. मेटाबॉलिक के लिए दे शुड गो इन द सेम डायरेक्शन, पीएच इंक्रीज तो CO2 आल्सो इंक्रीज, पीएच कम तो PCO2 आल्सो कम. ओके, डोंट सी द बाइकार्बोनेट नाउ. ओके, जस्ट सी पीएच एंड PCO2. So what do you get? Four major disorders you'll get as respiratory acidosis, respiratory alkalosis, metabolic acidosis and metabolic alkalosis. ठीक है, respiratory acidosis में क्या हो रहा है? pH कम हुआ, PaCO2 ज्यादा हुआ, बाइकार्बोनेट भी ज्यादा हुआ. अभी बाइकार्बोनेट we are not considering. Okay, respiratory alkalosis, pH increases, PaCO2 decreases. Metabolic acidosis, pH decreases, CO2 decreases. Metabolic alkalosis, pH increases, PaCO2 increases. Okay, same direction metabolic, opposite direction respiratory. इस step में यही याद रखना है. Fifth step, now we need to see, since अगर हमारा primary disturbance है, if it is respiratory, okay, then we'll look for whether it's acute or chronic. ठीक है, जैसे हम बोलते हैं ना acute respiratory acidosis या chronic respiratory acidosis, तो this we need to find out in this step. Okay, if it is metabolic then this step is not needed. Okay, so acute respiratory acidosis, we have this formula, these formula you need to remember. Okay, change in pH 0.008 into CO2 minus 40 for acute, chronic 0.003 into CO2 minus 40. 40 कहाँ से आया वैल्यू? जो हमने CO2 का कैलकुलेशन के लिए वैल्यू लिया है नॉर्मल. Acute respiratory alkalosis 0.08 into 40 minus PCO2, chronic के लिए 0.03 into 40 minus. ठीक है, whatever value you get, you'll match it up with the pH and you'll see whether it's acute or chronic. Okay, sixth step, now we'll check for the compensation. What does the body try to do? It tries to bring back the pH to normal by various mechanisms to correct the acid-base disorder. Okay, it requires normal kidney function and lungs function to perform this, right? Compensation never overcorrects the pH, and normal pH can also have an underlying mixed disorder. This I've already told you. Okay, so now if there is a respiratory disorder, then we'll look for a metabolic compensation. Okay, this table is known as a 1-2-4-5 rule. What do we do in this? I'll explain you when we solve the case scenario, but just here you understand that इसका क्या मतलब है? Every 10 mm change in carbon dioxide, मतलब 40 हमारा normal baseline CO2 है. In acidosis, अगर it increases to 50, supposedly 10 से बढ़ा, तो हमारा acute respiratory acidosis में the bicarb will rise by 1. Okay, अगर 50 का ही CO2 है, chronic में bicarb will rise by 4. Okay, in respiratory alkalosis, अगर हमारा CO2 has decreased by 10, supposedly 30 हो गया है 40 से, तो bicarb will decrease by 2 and chronic में bicarb will decrease by 5. Okay, तो 1, 4, 2, 5 हम ऐसे याद रखते हैं टेबल. Now, metabolic disorders के लिए we have a respiratory compensation. So there is a Winter's formula. This formula is very important. So if you have a metabolic acidosis, the compensation का formula will be PCO2 is equal to 1.5 into bicarbonate plus 8 plus minus 2 is the range. Okay, supposedly 20 आया, तो हमारा value will be 18 to 22. For the metabolic alkalosis, PCO2 is equal to 0.7 into bicarb plus 21 plus minus 2. Okay, if you get a value of the PCO2 calculated and what is there in the ABG the same, then means it's a complete compensation. If the PCO2 is more than expected, that means there's some extra respiratory acidosis. If there's a PCO2 less than expected, then means there's a respiratory alkalosis. Okay, so that was the respiratory and compensation part. Supposedly you found a metabolic acidosis. Okay, next step, उसके बाद we need to calculate the anion gap. What is the anion gap? It's based on the concept of electroneutrality. जितना positive होना चाहिए उतना negative होना चाहिए ions, okay, in the blood. So this is the whole concept behind it. So the unmeasured anions and unmeasured cations are calculated. The final formula which comes out to be is sodium minus the sum of the chloride plus bicarbonate. Okay, in few books you'll also find sodium plus potassium minus chloride plus bicarbonate, but potassium has a low value, so we remove it. So the final calculation is sodium minus chloride plus bicarb. Okay, the next, if you'll see, it's there's something called as corrected anion gap. What does that mean? If the patient has a low albumin, okay, they found that in low albumin states the anion gap value also changes, so there we need to correct have a corrected anion gap. So जो anion gap you've calculated supposedly 12, so 12 plus 2.5, 4 minus serum albumin, जो भी patient का albumin है, suppose it's 2, so 4 minus 2, 2 into 2.5, okay, and that means 5 plus supposedly your anion gap is 12, so 17 will be your corrected anion gap, जबकि your anion gap came out to be 12, but corrected anion gap due to the albumin wala correction comes out to be different. Okay, 8, I'm just reading it, you don't need to worry about it, it's not for your level, but just to complete the whole discussion. Okay, so if you have anion gap, if you find a positive anion gap, supposedly the anion gap, high anion gap, then we calculate the delta ratio. The formula goes by anion gap minus 12 upon 24 minus bicarbonate. So these are the ratio. If it is less than 0.4, it's a hyperchloremic nagma. Less than 1 is high anion gap and normal anion gap acidosis. 1 to 2 is pure anion gap acidosis. More than 2, again high anion with metabolic alkalosis. Okay. If the anion gap is normal or non-anion gap, then you need to see for the urinary anion gap, which formula is urine sodium plus potassium minus chloride. The value, if it is positive, then it's a renal cause that is seen in renal tubular acidosis. If the value comes out to be negative, it's a GI cause like in diarrhea. Okay. And last step, if the primary disturbance come out to be metabolic alkalosis, you should always check for urinary chloride. If the urinary chloride is less than 25, it means that the body will respond to the chloride NS. Okay, so you can give fluids. Okay, if the chloride levels is more than 25 or 40, then you look for other causes, which is not needed for you. So examples of respiratory acidosis, there are many. Okay, alveolar hyperventilation, CNS depression, like some sleep disorders are there, OSA is there, some obese patient is coming with it, neuromuscular disorders, myopathies, neuropathies, there's flail chest, there's kyphoscoliosis, where the wall movement is restricted, pneumothorax, pleural effusion, some obstruction in the airway, emboli, pulmonary edema, aspirations, ventilator malfunction is happening, or malignant hypothermia, intensive shivering, seizure activity. All these causes increase in the carbon dioxide production, leading to respiratory acidosis. Okay. Examples of alkalosis respiratory, if some patient is coming who's anxious, pregnant, all these causes increase in tachypnea and increase in respiration, which will cause further washout of CO2, leading to respiratory alkalosis. So examples will be hyperventilation, anxiety, hypoxia, pneumonia, again embolism, liver disease, etc. High anion gap metabolic acidosis. This you should remember the mnemonics I have labeled here. There are two mnemonics. Either you remember mud pies or gold mark, which has recently come up. So M for methanol, U for uremia, D for DKA, diabetic ketoacidosis, P for paraldehyde, I for isoniazid, which is a very important drug for TB, iron, lactic acidosis, E for ethanol, S for salicylates. Okay, same you can remember as gold mark. It's your choice. For normal anion gap metabolic acidosis, the mnemonic lies harder: hyperalimentation, acetazolamide, RTA, diarrhea, uretrosigmoid fistula, and pancreatic fistula. You should remember these mnemonics by heart. Okay. And last, metabolic alkalosis examples. There will be the broad example. Either it's an intravascular volume depletion or an intravascular volume expansion. Okay. So depletion can be due to maybe the patient is coming with vomiting, diarrhea, the patient is on loop diuretics. Okay. And volume expansion due to multiple other factors like high aldosterone levels, high renin levels, okay, Cushing syndrome, renal insufficiency, etc. Okay, so this is all about. Now we'll begin with some MCQs. Okay, I would like everybody to participate. It's very simple, 5-6 MCQs. Okay, please answer in the chat box. And good afternoon, Dr. Priteema. I think you can also.
Yeah, hi. So I would like to request all the participants to switch on the camera and your mic so that we can see everybody, because now this is a question answer session, so I think everybody can come online. Anybody? I can't see Juhi, you and me only. Because I'm seeing this participant list. There are hardly 9 participants, and out of that, I think 4 students are there, if I'm not mistaken.
Okay, so I would like everybody, either you can put it in the chat box if you're scared enough to answer. You can put it in the chat box.
Yeah.
It's a very simple MCQ. Which is the most common site used for ABG sampling? Brachial artery, radial artery, femoral artery, dorsalis pedis artery?
Yeah, I think everybody answer right. Okay. There are 4 students. One is iPhone. I don't know who is this iPhone. And Pavni, Brahmara, and Mansuri. Yeah. Okay.
The next MCQ, the answer is radial artery, right? Okay, you can take from all the 4, but the most common, and because it's the most superficial and easily accessible, we take the radial artery. Okay. The next, which of these are the factors affecting the ABG values? Okay. Temperature, air bubbles, heparin, all of the above.
Yeah. Pavani answered. I think everyone answered. I think three student answer the option 4.
Great. Okay, so everybody is listening. Great. Okay.
Mhm.
Third MCQ. What is the normal pH for optimal body functioning? Okay. 7.15 to 7.25, 7.35 to 7.45, 7.05 to 7.15, 7.50 to 7.60.
All 4 candidate answer 2. Option 2.
Great. Very good. Fourth, which of these causes high anion metabolic acidosis? Try to remember the mnemonic, and the options are DK, renal tubular acidosis, pancreatic fistula, diarrhea.
So only 2 answers. iPhone answered option 1 and Mansoori answered option 4. Out of 4, 3 candidate answered 1 and 1 candidate said 4.
Okay. So you need to remember the mud piles, okay?
Mud piles, yeah.
DK. Okay, so answer is diabetic ketoacidosis. The other 3 are the answer for the non-anionic. Okay, and the hard up. Remember? Okay. What is the correct formula to calculate anion gap? Okay, just try to answer this. Very important.
Okay, iPhone answered option 2. Mansoori answered option 1. Pavani answered option 2. One more. Brahmara answered option 2. So out of 4, 3 answered option 2 and 1 answered option 1.
Very good. So right answer is 2. Okay, so positive minus negative. Negative क्या है? Chloride and bicarbonate are negative ion. So we take their stuff minus sodium. Okay, so no, 2 is the right answer. Last, the most important equation or the central equation of the acid base balance was given by Winter, Henderson, Hasselbalch, Morgenroth, Lorenz, Emmett.
Okay, iPhone answered option 2. Who is this iPhone? Can you write your name in the chat box? iPhone. Reshmita Devi. Good, Reshmita. Okay, we have only one. Okay, 2 answer. Pavani. Everybody answer option 2.
Great. Okay, so I think they did quite well in the MCQs.
Yeah.
Okay, so now we move to the case scenarios. Okay, we'll solve it together. So I've tried to keep it very simple. Supposedly a 67-year-old male, a smoker, COPD coming with breathing difficulty and drowsiness with this ABG. pH is 7.27, PCO2 is 58, bicarbonate 26, PO2 of 70, and ion gap of 12. Okay, so how will you approach? Anyways, we can't unmute them, right?
Let me try. So I think let me unmute iPhone.
Don't be scared. Try to answer whatever you know, okay? Me and ma'am will try to help you as much as possible, okay? We are here to clarify.
Yes. iPhone, you can talk, I think.
Okay, ma'am.
Yeah.
So it looks like it is a case of respiratory acidosis.
Very good. But then we'll go step by step.
Yes.
Okay?
So we have to see the oxygenation PO2 level also is decreased. So
Right.
maybe we'll start the patient on oxygen support.
Very good. Very good.
And as the patient is drowsy, so
Yes.
maybe NIV will be the option.
Very good. Very good. Very good. So that was your first step. Now, second step.
So second step was validity, right?
Yes.
Yes, ma'am, validity.
So check for the validity. I am saying that this ABG is valid. Now, third.
Third, what we'll see? Acid या alkali है, क्या
It
है?
is acidic, so 7.27. It is acidosis.
Very good.
Yes.
Fourth step, अब हमें प्राइमरी डिस्टर्बेंस पता करना है. देखो
Yes,
pH and
we have to see whether it is metabolic or respiratory.
right.
So as
pH,
PCO2 is increased
hmm,
and bicarbonate is in normal range, so it is a respiratory issue.
बाइकार वील फॉरगेट. अभी मैंने क्या बताया था,
Yeah.
बाइकार नहीं देखेंगे, बस पीएच एंड पीसीओ2
Okay.
बताओ. पीएच किस डायरेक्शन में जा रहा है?
pH is decreasing and PCO2 is increasing.
तो दे आर
So
गोइंग इन
they are in opposite direction, so it is a respiratory.
वेरी गुड, वेरी गुड, वेरी गुड. ठीक है, तो रेस्पिरेटरी हो गया. अब क्या देखेंगे? रेस्पिरेटरी पता चल गया तो
I think we have to see the compensation now.
कॉम्पेंसेशन से पहले एक छोटा सा और स्टेप. अक्यूट है कि क्रॉनिक है?
Yes, yes, yes. Sorry, acute or chronic.
हाँ, फिर हम वो फॉर्मूला लगाएंगे. फिर अगर अक्यूट है सपोजिटली या क्रॉनिक है, देन वी लुक फॉर कॉम्पेंसेशन है कि नहीं. अगर
Yes, yes,
है ना और कॉम्पेंसेशन है तो फिर वी हैव अ डायग्नोसिस. ठीक है,
yes.
वेरी गुड, बहुत
Okay.
अच्छा.
Thank you.
चलो,
Thank you.
वील सी द सोल्यूशन नाउ. ठीक है, ऑक्सीजनेशन आई एम ओमिटिंग, हमने डिस्कस कर लिया. स्टेप 1 वैलिडिटी. ठीक है, फॉर्मूला हमने याद 24 इंटू पीसीओ2 बाय बाइकार्बोनेट. पीसीओ2 यहाँ पे 58 है, बाइकार्बोनेट इज 26, सो द वैल्यू कम्स आउट टू बी 53.5. ठीक है, ये टेबल
Yes.
देखिए तो H प्लस आयन का देखो 53 कहाँ पे है, 50-56 के बीच में आएगा सपोजिटली. तो रेंज वुड बी 7.30 से 7.25 के बीच में पीएच होना चाहिए. हमारा पीएच 7.27 है, दैट मींस इट्स अ वैलिड एबीजी, है ना.
Yes.
स्टेप 2 में लेस देन 7.4 एसिडीमिया है.
Acidic.
थर्ड में पीसीओ2 एंड पीएच ऑपोजिट डायरेक्शन, रोम निमोनिक वी हैव रिमेंबर्ड, राइट. तो रेस्पिरेटरी
Yes.
डिस्ट्रेस. ठीक है, फिर अक्यूट है कि क्रॉनिक है कैसे पता करेंगे? चेंज इन पीसीओ2. ठीक है, 40 इज अ नॉर्मल वैल्यू जो हमने कैलकुलेशन के लिए लिया है, एंड पीसीओ2 हियर इज 58, राइट. सो चेंज इन पीसीओ2 18 आया. पीएच डिक्रीज कितने से होगा? हम फॉर्मूला में लगा देंगे 0.008 इंटू 18, जो हमारा ये चेंज निकला है, राइट. तो ये वैल्यू है
Yes.
0.4. ओके, तो अब हम कैसे निकालेंगे? हमारा नॉर्मल पीएच व्हाट डिड वी रिमेंबर? 7.4.
7.4.
उससे हम माइनस कर देंगे 0.14, विच विल कम आउट टू बी 7.26.
7.26.
दिस विल बी आवर वैल्यू. और हमारा पीएच एक्चुअल में कितना है? 7.27. तो ऑलमोस्ट सेम है, दैट मींस इट्स अ अक्यूट रेस्पिरेटरी एसिड. ठीक है, अब
Yes.
ये तो हमारा अक्यूट का हो गया. अब वील चेक फॉर द कॉम्पेंसेशन, है ना. पीसीओ2 इंक्रीज कितने से हुआ? 18.
18.
बाइकार्ब वाला टेबल याद है, 1425 वाला, है ना, 1425. तो उसमें अक्यूट रेस्पिरेटरी एसिडोसिस के लिए 1 था वैल्यू. सो पीसीओ2 इज इंक्रीजिंग बाय 18. बाइकार्ब विल इंक्रीज बाय 1 इंटू 18 का 1.8 करा, तो 24 प्लस 1.8 26, 25.8 रफली 26. और हमारा बाइकार वैल्यू कितना है एक्चुअल में?
26.
तो इसका मतलब इट्स अ कॉम्पेंसेटेड acute respiratory acidosis.
Respiratory acidosis.
Understood?
Okay.
ठीक
Yes.
है, चलो अब नेक्स्ट केस कोई और करेगा.
Yes. कौन करना चाहेगा? I think Pavani, will you do? Let me unmute. Vinod, you want to do it? Vinod, unmute yourself. Vinod,
Try to solve it. We'll help you.
yeah. Vinod, are you there?
Try. See, she's tried so well, your colleague. You know, you should try at least. तभी समझ आएगा, otherwise नहीं समझ आएगा.
Mansoori? Mansoori, unmute yourself. This is not exam, guys. You can try, you can make mistakes here, but you can't make mistake in exam.
If you'll make a mistake, we'll correct you, you know. जो भी doubts है, we can understand also where you're going wrong. At least step by step try karo, you'll be able to find it.
Pavni, unmute yourself. Nobody want to. Pavni is there, I think. Pavni, are you there? I have given permission to everybody, but
The one who was trying earlier, ma'am, can she try again? If she wants.
She can try again. Rasmita?
When first step is you have to check the validity.
Yes, very good.
So, according to the formula, hydrogen ion, if it is 7.4, it will be. If you put the formula, it is 4.
Validity, we've checked the validity. And what was the formula for it?
PCO2 by bicarbonate into 24.
Very good.
It should be the sodium hydrogen ion concentration.
Right. Very good. Okay. Supposedly your ABG is valid. Now next step.
Next we have to see whether it is acidemia or alkalosis.
Very good. So what is this?
So the pH is more than 7.35, so it is a alkalosis.
Right.
7.45.
7.54.
45.
4-5 से ज़्यादा है. Right? Ma'am is trying to say 7.4.
Sorry, yes, ma'am.
Then
you have to identify the primary disturbance.
What is that now here? देखो pH और क्या देखेंगे? PCO2.
PCO2 is yes, pH is increased, PCO2 is decreased, and bicarbonate is also decreased.
Forget the bicarb, right? So pH and PCO2 going in opposite
both
direction.
are opposite, so it is a respiratory.
Absolutely.
Very good. Forget the bicarb in this step, okay? Primary के लिए हमें सिर्फ pH and PCO2.
Yes.
Okay, don't complicate things for yourself. Just pH and PCO2.
Yes. Next, we have to see whether it is acute or chronic.
Very good. ठीक है. I'm not asking you the formula. थोड़ा याद करने में time लगेगा, but very good. You should know the step. Then
if it is acute, then we have to look for the compensation.
Very good. Acute या chronic कुछ भी अगर होगा हमें compensation check करना ही है, right?
Yes.
ठीक है. So validity we have checked.
Yes.
Okay. Valid. Step 2, alkalemic. We were right. pH and PCO2 opposite direction.
Yes.
Respiratory disturbance, right?
Yes, ma'am.
Now acute or chronic, we'll put it in the formula. We'll see, है ना? Yes. I've calculated, so I know it's acute. But then you people might need to put all the 4 formulas to come to know what is it, right?
Yes, ma'am.
So this I've got 7.53 is my value, which is matching my pH, right? So it's acute respiratory alkalosis. Okay. Now we'll look for the compensation. Alkalosis का देखो याद आया वो table 1425. तो 2 वाला आएगा, right?
Yes, ma'am.
This will be 24 minus ये 20.8 होना चाहिए, and R corresponding bicarb is how much? 20. Almost similar. So it's a compensated acute respiratory alkalosis. Understood?
Yes.
Next.
Very good.
Somebody else should try this.
Mansuri,
try.
Mansuri, you can unmute yourself. Mansuri, Mahi, Sharmila. Anyone want to try?
How will you answer an exam if you don't try right now?
Anyway, I think continue with Rashmita.
Rashmita, you only solve it then.
Let her
It's
gain
your
more
practice.
confidence.
Yes, that's what.
She will be fearless in exam for sure.
Yes. Rashmita, try this.
Okay, Rajeshwari want to.
Okay.
Let Rajeshwari do.
Yeah.
Rajeshwari, unmute yourself. Are you there, Rajeshwari? I don't know. She raised her hand and now she is missing.
At least try step by step. See, Rashmita also answered, two such good efforts she put.
I think continue. Yeah.
Yeah. Right. Again, we'll check for the validity. So it's a valid ABG. Okay. Now check for the pH, 7.4. If it is more than 7.4, which is here, pH says 7.58. So it's alkalemic. Step 3, we'll check for the pH and PCO2. Check whether it's the same direction or the opposite direction. pH is increasing, PCO2 is also increasing. So they are going in the same direction. So it will be a metabolic, right? Metabolic. So it's a metabolic alkalosis. Okay. Now we'll look for the compensation. So metabolic का compensation कौन करेगा? Respiratory करेगा. So respiratory compensation. So remember two formulas. One was the Winters and one was the alkalosis के लिए. So 0.7 into bicarb plus 21 plus minus 2. So the answer is 51 to 55 is our range. Our PCO2 is 55. So it's a
compensated
metabolic alkalosis. And I told you the last step, if it is a metabolic alkalosis, we should see the urine chloride level. अगर वो दिया हुआ है जैसे इस ABG में they've mentioned at 20, so urine chloride, if it is less than 25, it is saline responsive. Okay, so you can see the history also. The patient came with diarrhea, है ना? So
yes,
she will respond to the saline. Okay.
okay.
Last case. This I will tell you a bit complicated just because metabolic acidosis also I wanted to cover. That's why this case. Okay, just go through with me in this one. So, 63-year-old male, a case of chronic renal failure, came with breathlessness, reduced urine output, and vomiting. Okay, so this is the following ABG. Okay, so how will we proceed? We'll check the validity. It's a valid ABG. Step 1, we'll see for the pH, right? What is the pH? 7.18. What is it? Acidemia हो गया, ठीक है? Less than 7.4, acidemia. Step 2, now we'll look for the pH and PCO2. देखो किस direction में? pH is increasing, CO2 also decreasing. Same direction means metabolic, right? Now we'll look for expected. Now we look for the compensation, है ना? अब metabolic acidosis का compensation कौन करेगा? Winter's formula, right? 1.5 into bicarb plus 8 plus minus 2 is the correction factor, range factor. So 17.7 to 21.7 is our value. Okay, where our CO2 level is 21, so it is a compensated one, right? Compensated metabolic acidosis. हमने अब क्या बताया था? When we have a metabolic acidosis, we should calculate the anion gap. Okay, anion gap formula was sodium minus chloride plus bicarbonate. Check the values, they've written everything, right? We'll put it in the formula. The anion gap comes out to be 30. The normal anion gap value is क्या? 12. Okay? है ना? 12 plus minus 2 and plus minus 4 भी बोलते हैं कहीं कहीं, तो 8 to 16 जैसा sort of range है. But for calculation we take it as 12. तो इसमें albumin भी इसने दिया हुआ है, if you'll see. हमारा normal albumin around 4 होना चाहिए. So it's a hypoalbuminemia state, so they have taken out the corrected albumin also. Okay. which is 36. उसके बाद तो क्या क्या हमारा हाई अनायन गैप मेटाबॉलिक एसिडोसिस. मेटाबॉलिक एसिडोसिस तो पहले से ही हमने डायग्नोस कर लिया था. हाई अनायन गैप क्यों? क्योंकि मोर देन 12 का है तो हाई अनायन गैप मेटाबॉलिक एसिडोसिस. ठीक है. फिर गैप गैप रेशियो हम निकालते हैं. हाई अनायन गैप नॉट इम्पोर्टेंट फॉर यू. इसमें ये मिला अल्कलोसिस भी है, तो इट्स अ मिक्स्ड acid based disorder where we have a metabolic acidosis, high anion gap due to the kidney failure, and metabolic alkalosis also due to vomiting. ठीक है. इतना डिफिकल्ट होगा नहीं, ये बस एग्जाम्पल था टू कंप्लीट ऑल द स्टेप्स बेसिकली. ठीक है. So take home message one, as I began my lecture with a picture where the ABG had your head scratching, I hope that after this presentation it's much simpler for you, even though I wanted more participation. But good Rashmana, I'm very happy you at least tried and you put such a good effort. So understanding ABG is not a magic, but you need to have a continued practice to develop an art. Okay, so this is my take home message for everybody. Any questions is welcome.
Thank you so much, Dr. Juhi. So nicely explained. I would appreciate it. I think there is one question. Thank you, ma'am. Okay, how to identify ABG, acute respiratory failure, chronic respiratory failure? Who is this? Vinod. Vinod is asking how to identify ABG, acute respiratory failure, chronic respiratory failure.
I have.
So this is Vinod. This is not acute respiratory failure. Failure is respiratory failure is a different terminology. We are talking about the ABG. It's acute respiratory acidosis or chronic respiratory acidosis. What you are trying to ask?
Yes.
Right. So this is the formula which Dr. Juhi is showing. Now, failure is a different terminology. Okay. So this is acidosis. This is the formula through which you can identify that it is acute respiratory acidosis or chronic. I think you joined very late.
Yes.
Because I have not seen you during the session. So I think this this lectures video will be available on the ISSM website. You can go through it and understand. So I would like to appreciate the question which is not covered in this lecture. Anybody have any queries, any doubts, any questions?
At least from tomorrow when you guys go, just try to take 1 or 2 ABGs and try to go through the formulas and everything. Once you start practicing, you will have an idea, and you don't need to go into the delta gap and all. That was just to complete the whole lecture because I wanted to put in the word. But you just have to focus till anion gap. अगर anion gap भी नहीं हो रहा है वो भी चलेगा, but at least metabolic acidosis, respiratory acidosis, alkalosis, इतना भी you should come to know.
Any questions? I think there is no question in the chat box anymore. So I think this is very nicely and detailed covered by Dr. Juhi. So guys, I would like to add on one or two lines. One thing is that the ABG and case scenario. These are the two important things you have to appear for the exam. There will be, I think, 3 cases for you in the exam and the table viva. In the table viva, you will have hardly 1 or 2 ABGs. The one table viva will have 10 minutes. And in 10 minutes, you will have not only the ABG, even the X-rays and other lab reports, which you have to interpret. So you will get hardly 1 or 2 minutes to interpret the ABG. So whenever there is a ABG given to you, you have to mention one line that I would like to check the validity step. So the moment you say, the examiner will say, okay, it is valid. Now go ahead. Now the second step is either it's acidic or alkalosis. Second, then it is in the same direction or the opposite direction. Then once you make out this is respiratory or the metabolic, you have to go to the next step, acute or chronic. There is a formula for that, which already Dr. Juhi has mentioned. And then you have to check for the compensation. And after that, if there is a metabolic acidosis, you have to go to the anion gap. I assure you that nobody will reach to this level in your exam. But it's better if you learn about it and you practice in a daily your patient care. You will remember this if you at least practice 1 ABG daily on your bedside. Because definitely you guys are taking care of the ICU patients. and you will definitely have one ABG for each and every patient. If you are taking care of one patient, you will have one ABG in your hand daily. If you have any doubt, please ask your ISO consultant to help you out. And if you have any questions, Dr. Juhi's mail ID or my mail ID will be provided by the IACCM site, and you can just write to us and we will reply to you. We are here to help you to understand and to clear your exam.
Yes.
And I will appreciate the IACCM team if for next time the more participation will be there, because hardly I think 4 or 5 students are there, and I don't think we have only 5 or 6 IDCCN student register for exam. Second thing is, the more the participation actively, more you will learn. Like Rashmita, I think Rashmita will remember that how to at least go through the first 4 or 5 steps. She will remember that. Even we doctors also get difficulty in the after 7 step, like considering the anion gap and then the delta gap. I assure you, even our junior doctors also get confused in that. These are the 4-5 steps. If you understand that, nothing better than that. Okay. So thank you, Dr. Juhi. I'm extremely sorry I could not join on the time because I was going through some meeting and it got delayed for 10 minutes.
That's
Thank
all
you
right.
so much.
I really am very happy that you joined at least for the later half.
No, I think I joined in 15 minutes.
Oh,
You
great.
were already on, I think, first step only.
Oh, great.
Even
Great.
मेरा भी revision हो गया है. Thank you so much. Yeah.
Thank
Okay.
you.
Thank you. I think we're done for the day.
Yes. I think we can even close the session if more questions, I think, right?
There is no question on the chat box. Yeah. Okay.
Okay. Thank you,
Good day. Yeah. Bye-bye.
Bye. Bye.